In this session, we're going to be looking at examples of good and innovative practice within community mental health services. We will be having 4 relatively short panels looking at different themes and trying to learn what changes the current system needs to enable innovative practice and to be spread more widely. With that, can I ask Jake to introduce himself, the first panel member?
I am Jake Mills. I'm the founder and chief executive of a national mental health charity called Chasing the Stigma, and an initiative called the Hub of Hope, which is now the UK's biggest and most comprehensive directory of mental health services. It's a charity that I set up as well through my own lived experience of living with depression, anxiety and a suicide attempt 12 years ago this year.
Thank you very much. Can I go to my first committee member, Joe Robertson, MP? Could you ask your first question, please?
Great, good morning. The Hub of Hope has been described by NHS England as the main signposting tool for mental health services, and you've already talked about its scale and size. Could you talk us through how you came to develop a tool that's been successful in that way, and particularly reflect upon those factors that's enabled it to be successful?
Yeah, absolutely. So it was something that, it's worth mentioning that I knew nothing about the world of mental health or about the help and support that was available when I was struggling with my mental health. And it was only through speaking publicly following a suicide attempt that I suddenly became thrust into that world, if you will. And that was because my story got picked up in the press, locally and then nationally, and kind of went viral. But as a result of me speaking publicly about my own mental health, people started coming to me and asking me for help. Because one, I believe there was a power of lived experience. Me talking about myself, I wasn't talking about anybody else, but people felt that I was talking about them. But then finding that help and support was so incredibly hard. So when people were coming to me and they were asking me, what should I do? I was saying, have you ever spoken to anyone about this before? And they were saying no. And I didn't know about the help and support. And so it simply started as a bit of a fact-finding mission for me, trying to find any support that was available. In my bedroom in my mum's house at home, just putting a list together. And I started to realise very quickly just how many community assets existed, how many voluntary sector organisations existed, how many peer support groups existed, that wasn't even to mention statutory services. And so we started to put it together as a list, which was just on a spreadsheet on my computer, but I thought, well, we need to make this publicly available. Why should you have to come through to somebody else to find this information? The truth of the matter is we can be born, raised, lived our entire life in a city or town, but not know about the mental health provision that is on our doorstep. And so after a lot of coffees and a lot of meetings and a lot of conversations, we eventually built it into a website and then into an app. And it's now a directory of services that consists of just over 14,500 services of all types. And so what we want to do is create consistency around signposting. So whether you are looking for support for young people or for older people or everything in between, we want you to be able to go on there, type in a city, a town, a postcode or nothing, just say find nearby and find the nearest local support to you the same way that you would if you're looking for a takeaway.
In your written evidence, you highlight the financial pressures caused by growing demand for your service, and you recommend long-term funding models to drive collaboration and integration. What could those funding models look like?
Well, first of all, it's worth mentioning that the Hub of Hope in the last year has had over 300,000 users, over 1 million searches. And a third of those users have come directly from NHS sources. We know that there's at least 75 NHS trusts, there's at least 50 government departments who are signposting to the Hub of Hope every single day. We're not funded, so we don't actually receive any statutory funding at all. I believe that right now we're developing or we're running a service that we're not being procured to do so. That's really, really important to the system, to the mental health system. But I'm also very, very conscious that there's a lot of pushing downhill. So, you know, signposting to community mental health assets and community support is important, but we need to be able to fund them to be able to do the work that they do. I think as a charity, and other charities, so many other charities who are propping up the work of NHS, particularly around government's recent ambition about from hospital to community, we're often kind of thrown a bone a little bit, a little bit of underspend here. Oh, if we can get you some money here, we'll do that. What we can't do with that is to demonstrate impact, is to demonstrate the evidence, to plan. I think what we need to do is we need statutory services to look at voluntary sector as an asset, as something that can absolutely they can embrace, not have a competition. Look at longer term contracts that we can work together. It's not about the voluntary sector taking something for nothing. It's about actually having a strategic partnerships, longer term contracts that can allow us to plan, demonstrate evidence. We're not going to demonstrate evidence in under a year. And so what happens is that if we've got a little bit of a pot of money, we can't really then do anything else with it at the end of that. So longer strategic partnership, proper integrated care when it comes to community, and really, the NHS do what they do well, the voluntary sector do what they do well, but having that real wraparound support is what I think that we need, and particularly with funding to be able to do it.
Thank you.
Before you go on, could we welcome our second panellist? I'm sorry to stop you, Joe, but our second panellist has now arrived. And could I ask you to introduce yourself?
Yes, thank you very much. My name is Darlington Zvionere, and I'm the head of clinical governance for Black Minds Matter UK. We are a charity that provides free therapy to the Black community, 10 weeks sessions.
Thank you.
Can I go back?
Thank you. Yeah, if I continue with you, Jake Mills, if that's okay. So the Hope in the Community initiative used insights from the Hub of Hope to develop a new model of support. I want to ask about data, how you use data to inform service design, and what broader lessons there are for good use of data.
Yeah, absolutely. So again, through creating a national directory, what we have done is we've generated the biggest asset mapping exercise that's happened in the country. So we can see where mental health provision is, and importantly, we can see where it isn't across the country. So we can see that nationally, and we can see it locally as well. But through the analytics, so it's a completely anonymised tool for people to use, but through the data analytics, what we're able to do is see insights of how people are looking for help and support and where they're looking for that help and support. That can be based on gender, on age, nationally, hyper-locally, time of day, day of the week. So for example, we could see that there was men between the ages of 34 and 50 in Croydon looking for self-harm support on a Sunday evening at 7 o'clock. Is that support there? If it isn't, then how can we then influence commissioning and policy to allow that support to be there to meet that demand? Hope in the Community is an initiative that we've been running, and we've got a partnership with Central North West London NHS Trust. We've got Hope in the Community Westminster, which is an initiative we launched in February of last year. What we were able to see is that people in the area were looking for voluntary sector support. That support wasn't necessarily available in the area, and this is communities who wouldn't usually engage with statutory services. And so we transformed an area in the Gordon Hospital, in the heart of Westminster, just a walk down from here. We transformed the former Section 136 suite. The NHS Trust have subsidised that space to make it free. And actually what we then do is we looked at the data of the Hub of Hope. We looked at what people were looking for and the need of the people. And we then went out to an application process and allowed voluntary sector organisations to run their services from this space for free. And that means then we've been able to develop a monthly calendar of events that are happening delivered by the voluntary sector that better meet the need of their community, but would integrate in people. So it's in an NHS building, but it looks like a Chasing the Stigma initiative. Hope in the Community is not a clinical space. It doesn't look like a clinical space, and we can then integrate the two. It's just one example how we can use that data to then really drive that change and and make something for the community.
Yeah, sounds very good. If I could turn to our second panellist from Black Minds Matter. How are Black Minds Matter addressing the barriers Black people experience in accessing support for their mental health? Could you just introduce us to that?
Okay, thank you very much. So what we're doing as a charity, we have gone in and tried to understand the needs within the Black community. So we have different pillars that we have, and part of that is awareness and advocacy. So what we do is we go around, through our workshops, through social media, trying to educate people regarding, what mental health is all about, and what they need to do in order for them to access mental health services. Now, predominantly, we offer one-to-one free therapy sessions to our community. But on top of that, we also run workshops, for other organizations and also our community in general, to introduce them to some of those things and discuss and most probably enlighten some of those stigmas. Where do they come from? How do you overcome them? What does it mean actually to go into therapy? So destigmatizing things like, you only go to therapy when there is something significantly wrong. So we are trying to be rather responsive rather than reactive to our community. So trying to usher them and also get them to understand their rights, when they're going to the GPs, and being able to explain themselves further regarding what they're going through with their mental health. Now, just looking at, I suppose, issues that they would have experienced, most probably trying to go onto the NHS, for example, to receive therapy. We are working in a very culturally competent and sensitive way, in the sense that we believe that understanding the individual, first of all, before we start treatment, sort of will cut down some of the timeframes, because some of our clients, on the feedback that we get, they talk about it was so easy to go through our therapy sessions because the therapist understood them before, getting to know their problems. So they didn't have to explain who they are as a person, but they then started working on their problems that they're having.
Thank you. Do you have any sort of case studies of, say, proactive support that you can talk us through as an example of the support you provide?
So yes, in terms of, as I was saying, with therapy, we've got a range of people who come to us with different, most probably presenting needs. One of the main things, or one of what I could consider most probably a good case study, is of understanding the importance of cultural sensitivity and competency in the areas. We had a client who came through and they were suffering from, or rather they considered to be autistic. They had been to different services. However, the problem was finding the right person who could actually understand them. Fortunately, on our list of therapists, we also have a therapist who is autistic. They worked together. It was a match in heaven, because when they came back to us, they were like, they speak the way that I speak. They understood me. I didn't have to go through all these other things that I'd gone through with other services. So that's one of the key things that keeps us going, and understanding that what we're doing is quite right. Because when we put our clients together, we just don't give them an area of, choose your therapist. They go through an assessment process with a qualified assessor. We'll sit with them, understand what their presenting needs are. Then we will also match them with the right therapist, so that we avoid people dropping out, unnecessarily, because, mind you, some of them have never had therapy before. So how do we expect them to understand what modalities or specialisms and all the rest, or some of the jargon that is associated with that?
Thank you. We understand you're looking to expand the work you do. What are the greatest barriers to expansion for you, and how would you navigate those barriers?
I think it's similar to what my colleague was just saying. Funding is the main barrier. Limited resources, cause some elements of even retaining some of our therapists, because we operate a cohort system and a wait list. So where we do not have enough funds, we are being forced to pause those wait lists, because we cannot, proceed forward. So what we're asking for is more or less, again, ring-fenced funding, that is for more than a year, to be honest, because in 1 year, similar to what my colleague was saying, we cannot show evidence or prove some of the issues that, if we try to go for tenders, that we're being asked to prove. But for more than a year, we can definitely show the progress, that's happening with the people. We can put in place the feedbacks, that we can go back and look at people. How's life after therapy? The aftercare that's required after therapy. Where are you? Even signposting people back into work and different things.
And a question to both of you. When thinking about people with severe mental illness in particular, which interventions do you think will have the greatest impact, particularly in terms of driving up sort of access to services and or reducing stigma?
I think it's important that we are differentiating between those with severe mental illness as well, because that is something that will require different treatments, and it will require different interventions. I think I'm actually very glad that you've asked it, because we do need to make sure that when we're talking about the conversation around mental health, we're not just putting everybody into that same bracket, because I think stigma comes from not having those really clear conversations about the difference between maybe the severe mental illness and the other end of the scale. So the interventions are going to be different. It's obviously going to be things that will require hospital treatment as well, will require more hands-on treatment and longer-term support for those people. But again, it's looking at the models that have been released in terms of the 24/7 pilots that NHS England announced last year, to be able to have those people still can be in the community, those people can still belong in the community. It's just find a way that we can integrate the support that they will need, the support that people on the more the other end of the scale that's not as severe mental illness. But there can still absolutely be a conversation about that can reduce the stigma that's associated with that, it's about making sure that we're quite explicit when we're talking about it, what we are talking about.
Joe, do you mind? Thank you very much. Do you mind if I stop you at
this
point?
Yeah, absolutely.
And what I'm going to do, Jen wanted to ask a supplementary question, but also, Jen, could you move on to your questions following your supplementary?
That's fine. Thank you, Chair. So I'm really very interested in this work around sort of reducing stigma, and we had someone come to give evidence in a previous committee who actually receives therapy through Black Minds Matter, and was extraordinarily complimentary about the work that you do. But he was very clear that for particularly black communities there is an enhanced stigma. How do you go about allowing people to sort of step away from that to access the services that they need?
So the main things that we've been trying to do is to educate people and making them fully aware, because where people are coming from, different experiences. I mean, the black community, there's so many different cultures, different, religions, if you want to put it across that way. But what we are actively doing is educating people in terms of, that we all do have mental health. Because the key thing is when people hear mental health, they do not want to talk about it sometimes because they're only associated with the negative. So we've got, when somebody's actually well, there's also mental health involved in there. When they're not well, mentally, it's also mental health. So educating them on those differences and, just getting them to understand that it's okay not to be okay, which is one of the key things where, especially in cultures and communities where it focuses on, power and, perseverance, rather than actually when someone is feeling vulnerable, it's actually okay, they're also crying out for help. So we are educating them through the workshops, through our social media, through the one-to-one therapy, through the assessments themselves, because sometimes when people come through for an assessment, they might not necessarily know what they need. They know that they need help, but through educating them through those assessments, we're finding that people are now going out to the community. We always believe in the ripple effect. It starts with one person and then it goes on further to everybody else that's around them, their families, their friends. Most of the recommendations that we get or the referrals are through family and friends. So in that sense, we are finding that is working.
It seems like both of you seem to be saying you're reaching people through non-traditional methods of access, and that's an interesting way to break down the stigma. I wonder, Jake, if maybe you can say something about some of the data that you see coming back. If you think that people that are accessing your app, which I've had a look at, by the way, and it's fab, if some of the people that are accessing that app are people that maybe wouldn't interact with mental health services in another way.
Yeah, absolutely. What we can see in the last couple of months is that 72% of people who are looking for help and support on the Hub of Hope are looking for voluntary sector support. To answer your question a bit more directly and on the back of what Darlington said, I believe fundamentally in the power of community who have a trust of their own community, who have the trust and knowledge and the understanding of their own community. Why are people more likely to go to voluntary sector organisations as opposed to statutory services? More often than not, it is that lived experience. More often than not, it's people they see, know, recognise, saying exactly what Darlington said, is that, you know, this is okay, I've been here. Once they see their own community engaging with that, they're much more likely to look at it. Again, you look back at how this started, I was only talking about myself, people coming to me saying, actually, I want to talk to you now. And they'd never spoken to anyone about this before. So our data is showing, you know, quite dramatically that people are more likely to look for that community sector organisation and support because they see their own people.
And how do you two find the interaction with the community mental health teams, if any at all? How does that work out? And I'm thinking specifically for people who have severe mental illness, as the scope of our kind of inquiry is looking at people who fall into that body and how community mental health teams can be transformed to better suit their needs.
So the two answers for that really is that we find it incredibly difficult every single day. I've mentioned about the amount of NHS organisations that use us, don't talk to us. You know, every day we'll hear people say how good what we do is, but the reality is that we've got 7 months left to exist as a charity. That's all the money that we've got in our bank account. We're having to find that money ourselves. Every time we have a conversation, whether it's with public health, with an NHS trust, with an ICB, whoever it might be, they'll say all the niceties, but they don't actually want to fund us and work with us because they want us to use it for free. What you're talking about again from that severe mental illness side of things, absolutely we need to be talking about how people can stay well in their communities, how we can keep people well within their communities. Once you come out of that statutory care, how do you stay well? And that's what we need to be working on, this integrated model. So yeah, we have a lot of niceties, and I'm sure so many of the other voluntary sector organisations have a lot of niceties too, but there's not an integrated, joined up way of working from my experience.
I think it's the same. I mean, given that we are not funded by any statutory bodies, we solely depend on donors and well wishers. We often find referrals coming in from GPs, the health and social care professionals that are around, and it gets a little bit frustrating because obviously that then we understand that they have got a pot of money for that, but they're now referring on to us, which then takes things away from what we need to do. However, we understand that sometimes it's about our clients having issues, I suppose, with the cultural competence and wanting to be understood from that level onwards. So the interaction is just referrals coming through, no explanations, no follow-ups, and most probably just, can you see our client, and we've got a wait list that's there.
And do you ever have any kind of interaction where a local community mental health trust or similar would come to you and say, look, this is what we need, and then you have those and you can say, look, this is what we need? Or is it much more piecemeal? There's just, we've identified, you do a thing, we're sending someone to you for this, rather than I would almost call it co-production or co-design?
There's not been any co-production or co-design. It's exactly what you're saying. We've got a client that requires the services or that we think will benefit from your services. Can you please see them? And then the follow-up emails, I think what we ended up doing is, the third-party referrals then increases our workload, and takes focus away from what we're trying to do as well. But if there are pathways, that are designed to streamline that, and we know that, okay, this is how we're working together formally, I think that will then help in the long run, rather than just having the referrals coming in through that way.
It's the same with us as well. So, we start with how we're described by NHS England, written into policy. We're written into the government suicide prevention strategy, described as the first place to go to find all this help and support. We know that through NHS 111 option 2, there's got to be some signposting as part of that. They just use us. So we don't even have conversations. We have to fight tooth and nail to get any conversation that we possibly can. There's no model to follow. They just use us for free because we're a free product. So much more that we can do when it talk about data and all the things that we can offer. But it's down to us, and often it comes down to a personal relationship, or not quite a personal relationship, but a relationship with an individual who might just get it and they might do it, but then as soon as that person leaves, there's no guarantee, and that's nationally and locally.
So one of the purposes of today's session is to look at models that work successfully and how they might be brought to scale up. And I get the impression, Jake in particular, you're hoping the community project is great, but you have lots of ideas about how that could even go further with good working with your local healthcare providers. What would you say has been the sort of key ingredients of your success, both of you, that you think could be replicated nationally? And I will say, because you have said a lot about how healthcare providers can go further at the moment, and do feel free to feed in that as well.
I think we particularly have a huge potential to scale up. What we would be able to achieve with the correct funding models and strategic partnerships that we aim to have, we can share so much in terms of the data insights to understand the need and whether the support is there to actually meet the need. In terms of hope in the community, again, this is a very simple model, which is not, it's really, really cost effective. When we talk about what the perfect model is around community mental health, it doesn't necessarily have to mean spending more money. Always spend more money, that's good, but it's about spending money better, and to be looking at who can help you do it. Not one person, not one organisation, not one system has all of the answers, and so we've got to be seen as equals in this. Being able to have the longer term funding, that wraparound support that involves all the parties, being able to learn from the data, learn from the insights, learn from the people who are using it. There's so much more that we can do, but we need that support, we need that guidance, we need it from national level right down to local and regional level to be able to allow us to achieve the potential that we know that we can achieve.
Thank you, that was really helpful. And Darlington.
Yes, I think it's on this same ideology regarding, again, the support, nationally, and having people to understand and setting up, areas. What we are trying to do effectively is, because predominantly we have been online, so we are now working towards actually going on the ground. We've been trying to work, very from the grassroots level, where we're identifying even the older generations, wanting but not knowing how to access therapy, because some of these things they're not spoken about. Those stigmas are still very much rooted in there, so having to go out and reach out and speak on a level where people understand on a one-to-one basis or on a group basis, building up communities that are able to sustain and support each other in the long run might be what will help to tackle the issues of mental health that we're finding within the black communities. So it's really down to scaling, really down to being supported, being seen as equals, rather than, oh, they're just a charity, they're doing things for free, but rather having those conversations, where actually what we're doing is working, and evidencing that, and if by all means having to replicate that, because this is about our communities and getting them to be well enough and resilient enough to do with the mental health that comes across.
Thank you so much. I'm going to pass back to the chair.
Thank you. Before we go on to the next panel, just quick rapid fire. I'm going to do it with every panel today. If there were two things out of everything you've said this morning that you want government to hear about scaling up, financing, whatever it would be, what would those things be? And I will start with you, Darlington. Just two things.
The two things will be, support with funding.
Yeah.
And also being given the voice to be able to represent our community and make changes within policies.
That's fine. And you said, Jake, over to you. Two things.
One, I would say, don't look at the voluntary sector as the enemy or as the outsider. What the voluntary sector do and deliver is so powerful and can absolutely complement what you want to do and are the key to do that. And the other thing is, don't just use us. Don't look at charities as if they're not businesses. If we want a good service and you want a good service, then you have to fund it, because you need the best people. And so look at that long-term sustainable funding.
Thank you. And at that point, can I thank you both for coming this morning? Absolutely brilliant. And we're just going to have a quick changeover to panel 2. And thank you, Darlington. Thank you, Jay.
Thank you very much.
Panel 2, come forward, please. Is the second panelist here? Karyn, Kirkpatrick. Is Miss or Mrs. Kirkpatrick here?
Sorry.
Yeah. Sorry. Right.
See the label.
I'm sorry to have to rush, but could I ask the second panel to just introduce yourself, and then we'll start asking questions. Over, who'd like to start? Mrs. Kirkpatrick?
Hello, my name is Karyn. I'm Chief Executive at KeyRing. We're a national organisation, a voluntary organisation, supporting people in the sort of preventative side of support.
Thank you for that. And Hassan?
Thank you. My name is Abdirahim Hassan. I'm the founder of Afrik. We run 7 buildings across North East London and 29 projects, 2 women's hubs, a problematic drug use space, a research lab, a systemic litigation space, and about 10 mental health projects too in community.
So I'm going to go straight over to Jen, one of our committee members, who will ask the first question.
Thank you very much, Chair. And this is addressed at Abdirahim, first of all. If you could just take us through some of the work of some of the culturally sensitive interventions that Afrik carries out. And I think I'm particularly interested, and I think the committee is as well, on how that addresses some of the stigma and how you're reaching out perhaps to a community that doesn't traditionally engage with mental health services.
So we run the 7 buildings which are co-designed and co-produced by community. Everyone in the organisation, there's 29 of us, has lived experience of mental health and other services. We run 2 women's hubs which are designed by black women who have lived experience of surviving genocide and domestic violence and other challenges. It's a space that is culturally sensitive, which is faith-based. It's designed with indigenous practice. It's not new because we've been running or have systems like this for over 400 years around our culture. The other spaces, our youth hub, one of the busiest now in Tower Hamlets, is designed by young people who live in the borough, who are predominantly working class, who have experience of serious violence and systemic harms. And similarly, the mental health work that we do is designed by people with neurodiversity who have serious mental illness, who just don't access services at the moment. One of our longest standing contracts is with East London Foundation Trust, and we've been working with ELF for 5 years now. We are co-located with the Mental Health Trust, which is quite rare in some respects. It's an award-winning service, the most engaged with service in the Isle of Dogs, which is quite a complex part of Tower Hamlets, because on one side, of course, there's Canary Wharf, and the other side you have severe deprivation, but it works because the team are blended. There are psychologists in that team, there are occupational therapists in that team, social workers, and the team at Afrik provide a service which is by and for people predominantly with SMI and physical health issues too. We design services that are language sensitive, that are aware of people's different needs, and that also support people from a whole human perspective, the housing issues, their welfare, etc. And I often struggle with the term stigma, because what it often does is it kind of blames the groups that are not engaging. I think that the challenge is the system itself, whether it's the NHS, public health systems, or local systems. In my view, they've been designed to create further sickness, and it isn't there to heal people, certainly. And that's what our experience is. So we're a group within a large institution, the NHS, that is providing a different way of working.
Thank you. So I'm very interested in the fact you co-design, you co-locate, you co-produce, would you say, as well? What have been the barriers to you in being able to do this? Have you found the local mental health services to be helpful and supportive? Have you found it there to be a difficult relationship at times? And how did you sort of overcome those?
We're very stubborn as an organisation, so I think that's helped to keep pushing through our ways of working. We believe in that people know what they need. We believe in self-determination. We believe that in anti-racism and equity as an organisation, that services should be designed with communities, not at communities. And predominantly it works very well because the people that approach our services also live within the communities that we reside. We all live in Tower Hamlets predominantly too. And it works because it's a tried and tested method. As I said now, for 5 years, hundreds of patients have been supported. And one of the key things is that you have a mental health trust that genuinely understands communities too in relation to ELFT. And we've had many challenges, like many organisations, and sometimes those challenges have been political. If you know about Tower Hamlets, it has a very complex political situation and an independent mayor, and equally teams of people that, from a public health perspective, won't always understand the communities they serve. We have always spoken about anti-racism and mental health services, and that sometimes that does challenge some people. And those are the challenges. From a funding perspective, we've worked very hard to try to sustain our organisation. We just received £1 million to carry on this work through an amazing foundation called the Tudor Trust Foundation, who truly understand health justice and health models. But from an NHS perspective, our drugs work, our mental health work comes from NHS England or the current and future models. And otherwise, we have experienced challenges around sometimes other community leaders who don't fully understand what health, in my view, liberation or health justice should look like for communities, particularly working class communities.
Thank you. And it sounds almost like the thing that drives you. You've got a very strong philosophical drive, and that you also have a health trust. You said that they are genuinely supportive. I'm quite interested in that because you also pointed out that there are some teams that will find your anti-racist work almost a challenge. Like, as I said to the previous panel, what we're looking for in today's session is kind of those pockets of very good and very good work and stuff that's working, and how that can be scaled up. What advice would you maybe give to either other NHS trusts or other groups that are looking to do similar work to you in other areas?
Listen, I think that's our biggest systemic issue, that we have multiple impact reports, some incredible impact reports that provide recommendations that can be implemented nationally. And we've presented that evidence to Parliament, we've presented that evidence at a local level, we've presented that evidence to almost most of the London trusts that we are familiar with. We're speaking at a CNWL, Central North West London conference soon to create what we think is health justice, but policy making that's rooted in love. And when we speak about love in healthcare, people look at us like we're dysregulated. But I think that's why so many of the systems that are designed don't work, because they're often designed with a minimal empathy or understanding of communities. So I think, for me, I would say not just to NHS systems, but to the police, to government, to the welfare cuts that are coming, to listen. Because these challenges are creating significant impact at a community level. I studied economics, and what I know about economics is that if you cut a budget in one area, it will impact certainly another. And I think that's what we're witnessing from a welfare perspective too, that our patients at a systemic level are already in crisis because of those cuts too. So I would say it's really important for just people to listen and to have that humility, especially because we really understand our communities.
You said something there about seeing people as an individual, and a lot of the lived experience sessions we've had, which I find particularly interesting, is when people have talked about their good mental health, if they're living with a serious mental illness, is they're seen as an individual, but it's not they're not just being treated for that condition, but there's an understanding of the things that contribute to their good mental health. Right. Whether that is, you mentioned social justice work, and I think someone said that they always have to have that kind of side of what they're doing, and other people need a creative outlet, other people need sort of physical health being really high on the agenda. Is there a focus in the work that you do, and do you think that is reflected by ELF, that they see people in that regard when you said you've got a good relationship, or do you think there's further work to be done?
I think there's significant work that needs to happen. Often when patients arrive at mental health services, they're treated in a moment of crisis, and they're seen as someone who needs something or who is broken in some ways. When you then diagnose the person as emotionally unstable borderline personality disorder, you're telling the person they have a disorder, that their traumas are not necessarily the reason why they're sick. I'm autistic. I have lots of lived experience in rough sleeping and many other aspects of my life, and I've survived all of that. And because, as I said earlier, as the founder of Afrik, I'm fairly stubborn. I believe that as philosophically, when I look at the Black Panther Party, for example, that we know what we need in our communities. We just completed a research paper funded by the London VRU, and in that research paper, 98% of over 110 young people that we surveyed experience violence on a daily basis in Tower Hamlets, emotionally, physically, and mentally. That's a significant proportion of young people. The other challenge with systems at a local level and national level is often we are not looking at communities and understanding that their built-up environment is traumatized. So we have landscapes that are traumatized. Our estates are traumatized. Air pollution is creating trauma. Schools are creating trauma. And I think that when we're diagnosing one condition, what we're not looking at is the person and where they live and what's contributing to their long-term sickness. And in my view, many parts of London are traumatized landscapes. And that's the challenge often we experience with clinicians and political leaders and others, that there is a misunderstanding about what living in a poor area where the system is deliberately discounting your opportunities can create for you, what it does to you, physically, mentally, and emotionally. And I am not speaking about something which is exclusive. The Centre for Mental Health speaks about this from a comorbidity perspective, from a life expectancy perspective, and those are the challenges we witness.
Thank you, and I'm so sorry we've not got more time, because I could talk about this all day, but I'm going to have to pass back to the chair.
Thank you, Jen. Can I hand straight over to Andrew, please?
Thank you very much. And going from geographically very specific and very much advocate, I'm advocacy-based, very impressed with that. Karyn, KeyRing, you're more nationally based. You were started in 1990, so
yes, started in 1990. We operate in 23 local authorities across England and just into Wales. But we have a very local, very localised community offer. And listening to my colleague here, I thought there's so much that resonated for me, so it's really, really interesting. We have a way of working, and we're not specifically a mental health support organisation. We don't offer therapy. What we do is support people who are eligible through local authority funding to get support, and we do that in a way which brings people together in a neighbourhood. So rather than having the model of local authority funded support where somebody has a need, a worker is sent to address the need, and then they go away and the person just gets on with their life, what we try to do is work with people in that neighbourhood, bringing people together, extending their connections and the resources that you use in that neighbourhood in order to improve their overall well-being, as well as responding to their eligible support needs or the support needs that they have. And that sounds very complicated. In real life, it is about working. Very, very often we find when somebody gets to the point where a local authority will offer them support, they have become really quite socially isolated. They're not connected with other people. They might not have family or friends that are helping them. That really affects their well-being. So they can be referred for all sorts of reasons, but that will be a fundamental part of our approach about working with people to look at what they need and what they want in their lives, what they can do for themselves, what other resources are available to them, and that is from us as an organisation, but also from community, neighbours, just people around them, the things that they're interested in, and then connecting people to those activities and that work.
So just on a practical basis, as I understand it, you also arrange or provide accommodation, and also as you were highlighted by the WHO, no less. There's three projects in the UK which were given kind of plaudits in that sense. I mean, you say you're not really a mental health organisation, yet the WHO describe you as such.
Yes, because we are addressing people's mental health needs,
yes,
and in a certain way. So an example that we would do, we work in Warwickshire, and we're part of the Wellbeing for Warwickshire collaboration, and that's a really interesting funded piece of work. It was a tendered opportunity, so it went out for competitive tender, but the council was really clear that they wanted people, a collaboration to really think about what do citizens in Warwickshire need, what would help them the most, and rather than commissioning lots of bits of different sorts of mental health support, what overall picture could come out of this. And in that process, they took away some of the blocks, like they said we will contract with each individual organisation. So that solves a lot of the tendering and contractual legal issues. It clears that place. What it leaves is a lot more time and space for the different parties in a collaboration to talk about and really think about, talking to the people they support about what do you really need, what would work across this area. And so in Warwickshire we ended up, or they've ended up with working with a number of different providers who all offer something different, but somebody wanting that support has one phone number, one front door, and gets passed to the right group of people. And it involves a number of things. I'm going to say Mind, Coventry, Warwickshire and Worcestershire, Quell, Recovery and Wellbeing Academy, and KeyRing as well. And we're all part of a mix. Right. Our bit is about helping people connect with their community and get back on their feet.
There's lots of process references there. I just want to try and get that down to the kind of nuts, bolts and bricks and mortar, as it were. So in terms of, how much professional assistance is provided, so whether it be administrative and coordinating things, how much volunteer effort is going in. Accommodation seems to be a kind of a key element of what you're doing. So are you a landlord? Do you provide services? Do you act as a go-between? I mean, in what way do you provide that stability in people's lives?
We're not landlords.
No.
We work very closely with housing departments and private landlords to help people find their own homes. We work with people living in their own homes, their own accommodation, and that's partly because we started from a point of view with people with learning disabilities who are leaving long-stay hospitals. What we do find now is that we do a lot of support work to get people engaging with mental health teams. We've got some really good examples around the country of NHS provision which works really well, and there's sort of an approach where those NHS trusts and local voluntary and community sector organisations have really pulled together. That works extremely well. There's a great example at South London and Maudsley Hospital, for example, and we're very connected there. So for us, we'll have a support element where our staff will be helping people access the mental health services that they need. So a lot of our work is about helping people maintain that. Often people will find it difficult to present at GP surgery, they'll find it difficult to follow up on appointments, they'll find it difficult to maintain their connection with that therapeutic or the interventions that they need. And this can be quite significant. My staff spend a lot of time with psychologists, psychotherapists, and making sure people are getting the right support. But that only takes you so far. And I think that's what you were talking about earlier. It's that bit about love in the community, about the thing that people say makes the biggest difference is very rarely my psychologist, although they may be getting really good support there. What they say that makes the difference is, I've got some friends now, I have some things to do, I know other people, I'm not alone in this
Can I
space.
just interrupt you there? So you're saying that a lot of the benefit of the service that you provide is through peer support and volunteers,
That's the bit that is the impact-driven side.
And I just want you to say that, that's all. I want to be clear that we're not talking about professionals basically hand-holding people as professionals to book appointments and to make arrangements for them, but you're actually building up a community of mutual support amongst.
Absolutely. Yeah.
And when you're commissioned by your 23 local authorities, are you always commissioned? Do you have a template offer to them, or do you tailor it to the needs of that particular local authority, or the NHS, the ICBs that are commissioning? And is it the ICBs that you're commissioning with, or is it the local authorities? Because you said local authorities, so I'm not clear.
Okay, we have a preferred model ourselves that we know works best. However, if you're doing any sort of work with the local authority, they will have a very clear idea of what they want, and so you need to adapt and fit with that. So we need to retain our core elements that we know work really well, and we won't take a commission that doesn't allow for us to do the stuff that we know makes the biggest impact. We work with 2 ICBs at the moment. That's been a bit of a slow burn. Again, it's a really interesting thing. One of the ICBs, we have a network up in Gateshead. They particularly want us to do a lot of health prevention work around that. That's absolutely fine. We can do that. But in order to make people engage and keep interested and keep focused, we do a lot of social activities and present that sort of health promotion work in a positive light, because we're looking at helping people change their behaviours, change the way they treat their treatment programmes, and really get engaged with it. So it's one of those things, a bit of a sleight of hand. There's what we do in the formal sense, and then what we do through the peer support, the community support, that helps people engage and keep them on track and not just lose out.
Okay, can I ask you both? Bring Abdirahim in as well. Just with regard to the process of commissioning from whether it be an ICB or a local authority. First of all, I suppose this one may be primarily aimed at Karyn. Just the national picture. There's I suppose a risk that if we're depending, and let me just be devil's advocate, if we're depending on the voluntary and community sector to provide services, then we could end up with a lot of kind of piecemeal patchwork, famine and feast around the country, places where you get fantastic services, like very impressed with what's going on in the Tower Hamlets, but then in a neighbouring authority, nothing at all. People are left. So can you just kind of address that? Do you know to what extent your fellows within the sector itself, there is a wider geographic view, and are you part of a kind of a peer support and a benchmarking, kind of group of voluntary and community sector organisations that talk to each other?
Yes, I can respond to that. We certainly are part of a group that talks to each other. The Association of Mental Health Providers gathers together all the community and voluntary sector organisations. Have got a huge membership and do enormous amount of work representing all the organisations, from tiny, very small organisations to really large charities. So they are sterling in their work. Around the country, I would say it is very, very variable, and it is getting more difficult. Yeah. And I would say that one of the things that I've noticed is the side of work that we do around prevention, about helping people reduce or delay or need more support, is being less addressed, because the impact that we make often is on the funding of other services. So when we work with an A&E department, with someone who represents every single day in order to change that pattern, or if we work with the ambulance service for somebody who calls them 10, 12 times a day, and we make that behaviour change, and we work with the person to redirect that need and find other things to do in their lives, the beneficiary is A&E and the ambulance service but the local authority is funding this, and they are no longer seeing that as their priority anymore. So if we intervene with somebody who is struggling with their behaviour, and we may be in meetings with the police and the town centre managers and, you know, mental health team, looking at how we help through our support work, help them adjust that behaviour. Again, from the local authority point of view, if they increasingly they're narrowing their interpretation of Care Act eligibilities and about what is reasonable for them to be funding. And I think, you know, we understand why, but the ongoing impact of this is quite significant. And I think the other thing, when you talked about traumatic neighbourhoods, you know, we've got a significant problem around housing. If you're in receipt of benefits, you have a restricted amount of money that you can spend on your rent, and the places where you can rent is becoming a smaller pool of places, and you're finding people with complicated needs all becoming squashed into smaller and smaller neighbourhoods, and that is very difficult for communities to offer good support to. That's a problem. The other problem we find...
I just wanted to bring, because of time limitation, I just want to bring Abdirahim in as well. This with regard to, I mean, you're focused on your own area. Not saying that you're not looking at how you compare with others, but one assumes that you are benchmarking against things that are happening in a wider sphere. I mean, where do you sit? How is the commissioning process for you?
We have worked in Barnet, in Harrow, in Tower Hamlets, Hackney and Newham, and 4 other boroughs too. And I think from a London perspective, certainly our experience is that we've been able to join still are in 8 different boards, various alliances, and we can see within the sector that there is definitely a push to reimagine healthcare. Certainly from a Coffee Afrik perspective, we welcome that NHS England is being restructured or changed or gone. We also welcome the 10-year plan and the other changes that are happening. But I think from our side, just as Karyn was saying, there is definitely a real crisis within the sector. More and more local authorities are pulling on us for advice around strategic needs assessments. Commissioning structures are changing. I think local authorities are too scared to work with local organisations in some boroughs, and they're working with the large national organisations like Save the Children, for example. And I think that is creating more complex crisis at a local level. I won't mention one organisation, but a large national one recently had their contract terminated, certainly where we're based in Tower Hamlets, because they really struggle to carry out outreach and to understand services from a mental health perspective locally. And I think that's what's happening at a local authority level, and also from our side, being able to benchmark great organisations we work with, like Decolonising Economics and Land in Our Names.
Okay, brilliant. And so just one last, just trying to bring this all together, is that, I mean, you mentioned the 10-year plan. You see all the talent out there in the voluntary and community enterprise sector. I mean, how should the government engage with you to ensure that all the talent that's there is harnessed and best utilised going forward? You know, so you're commissioned in a manner that you can be deployed to improve both the reach, the effectiveness, the efficiency of mental health services and support services throughout our communities. Because, as I say, there's a lot of talent, but it's disparate, it's piecemeal, it's famine and feast. How do we commission? I mean, we heard in the earlier session that from Stigma that they only have 7 months funding left. So obviously it has to be some confidence in terms of its longer term support. But so what advice can we offer the government to harness your talents?
In the past 10 years, we were not invited once to speak at a committee, although we submitted evidence. We were not invited to a roundtable. In the past 6 months alone, We've attended Parliament maybe 5 or 6 times, have spoken to the Secretary of State, the Minister for Public Health, and I think that when you don't create places that are equitable or accessible, it creates a dog-eat-dog sector, and that's exactly what's happened. I do think there's a big change at the moment. I think the systems have pitted us against each other. We're bidding for the same sorts of contracts. Right. We're working late nights, and we're using a corporate approach to community services. And I think that's where a lot of damage has happened. But also, I think on a very positive note, it's great to see this government open up doors so that we can be heard, but also to influence policy.
Good, Karyn.
I would agree with that. I think there is definitely a change in attitude politically at the moment. What I would say is what I would really like to see is looking at the biggest picture. What is going to make the biggest difference in this community? Communities, you need to look at everything. They all fit, all the pieces fit together. You can't just pick out and fund one tiny piece and think that's going to solve the problem. You can't put in a mental health support service and leave enormous housing issues, people not having enough money, poor quality schooling, all the pieces need to be looked at and brought together, because they are the things. And if you put more control back into those communities, I'm really interested in concepts like community budgeting. That would make such a difference for organisations like ours, because we could really start to talk about and think about how's this local spend actually spent, and does it meet what people who live here really need.
Thank you very much indeed. Thank you.
Thank you, Andrew. I am going to ask you guys the same question. As community-led organisations, or should I say community and peer-led organisations or initiatives, could I start with you, Mr. Hassan? If there was 2 things you would like the government to hear, there's been lots of richness in your input, but if there were 2 key things you'd say you don't want the committee to leave out from what you've said today, what would that be?
The first thing is to significantly reduce the waste and duplication. There's too much of the same things happening up and down the country. And I think it's really important to get value. And the other key thing is to have further policies, whether it's the 10-year plan or any other strategic framework, to genuinely design it with us, and for it to be purposeful and intentional and not at us. I think that's a really important definition, that it's as inclusive as possible and that we reach a diverse group of people like white working class communities, traveller communities and black and brown communities too.
Thank you. And over to you, Mrs. Kirkpatrick.
I think, what would I recommend? I really think that we should be rethinking about the whole of social care and our attitude, and perhaps taking the view from Social Care Future that everybody wants to live in their own home, doing the things they like with the people they love, and just getting on with it. And that's what support should be about. That's what it should be providing. And I spend a lot of time in meetings justifying and filling in forms and doing all sorts of things that do nothing to add any value to the offer that we have or other organisations have. Certainly I work with colleagues across many organisations, and we're all in the same boat. It's a complete waste of money and time, and I would love it to be different.
Right. Thank you for that, both. Thank you both for your brilliant responses, and thank you for coming today. We're going to move swiftly on to panel number 3, who will be the Innovation and Community Health Group. Who were they? Panel 3. Michael Crilly? What?
Crilly.
Michael Crilly and Janine Smith. Oh, that was a lot quicker. Oh, brilliant, brilliant. We're speeding up. Right, we're going to move swiftly on. So, can I ask, let me get my act together. Can I ask Josh? No, stop. Can you both introduce yourselves? Let's start with Michael.
Good morning, my name is Michael Crilly. I'm Director of Social Health and Community Inclusion at the Mersey NHS Foundation Trust, and I'm the Service Director for the Life Room Social Model of Health, which is a non-clinical, socially focused service that is run by Mersey as an NHS mental health provider.
Fantastic. And Janine?
Morning everyone, I'm Janine Smith. I'm Chief Operating Officer for Navigo. So we are a social enterprise delivering, amongst many other things, mental health services in North East Lincolnshire.
Thank you both. And can I move swiftly on to my colleague Josh, who will ask some questions. Thank you, Josh.
Thank you both. I've really enjoyed reading about both of your projects, actually, because I think with very different demographics, you kind of offer quite a lot of solutions that hopefully we can see replicated if we get this right. So I'm going to start with Michael. Can you set out how the Life Rooms model works, and in particular how you're able to bridge the gap between the NHS and the voluntary sector?
So the service originally launched in 2016 in response to the reality that a lot of our service users will say that actually the stuff that stops us recovering is the social stuff. We want great clinical care when we need it, but how do we move on? So effectively what we do is we have managed to bring together a raft of non-clinically focused services, teams and interventions, 6 individual teams that do one of 2 things. One will be an internal offer in terms of activating people around managing their own health and well-being, behaviour change, ultimately helping them to move beyond the dependency on services. And secondly, community access, where we network people to the voluntary sector. So to that point, we in particular have wrapped around our secondary and mental health clinical teams and services in a way to create a pathway from the clinicians who are often exercised by the fact that there are huge social issues presenting when they are trying to clinically work with someone, but they don't know what to do or they don't necessarily have the resources. So we have digital interoperability between our clinical information system and the digital social prescribing platform that the Life Rooms uses. So within 4 clicks, an individual clinician can make an express referral highlighting the social needs that the individual may have. Then that person is contacted by a Life Rooms Pathways advisor, a social prescribing link worker, who will meet with the individual service user, listen to their narrative, understand the issues that they have, and then again through our digital platform network them to in excess of 200 voluntary and community sector organisations, depending on what the needs may be. What we would find is each individual will probably require multiple social prescriptions, so it may involve referral to several voluntary and community sector organisations, and usually we will get better results if the individual also accesses the internal offer around health self-management and behaviour activation.
Okay, so just a couple of things that I pick up from that. So the first thing you talked about, kind of pushing behavioural change. Can you give an example of what that looks like?
So I suppose the Recovery College model has been around mental health services for a long time. We've
just assume we're all lay people. Can you tell me what the Recovery College model is, please?
Absolutely. So the Recovery College model would take lived experience of a mental health condition and marry it up with some form of professional expertise, give parity to that relationship in co-designing a learning programme that someone may access. So that could be around understanding anxiety or depression. It could be around building confidence or esteem, a range of clinical sort of support management programs, if you like, but also it can be broader than that. There can be a creative offering, so huge numbers of programs and activities that we've developed with creative and cultural partners, or around food and nutrition. So the whole gamut of how people might learn to skill themselves up, build confidence, take those into skills, and then ultimately activate themselves around their own health, so that they're less dependent upon resource structures that may be made through the organisation formally.
You talked about I think you said over 200 people that voluntary organisations you socially prescribe to. Is it your sense that there's a fairly broad variety of voluntary organisations on Merseyside, or do you think it's just that you happen to have the links?
I think there's a broad network. We're still lucky. We've a very strong and vibrant voluntary and community sector. Sometimes that's a bigger struggle in more recent times, as we've heard from some of the earlier panel sessions, in terms of the flow of funding. I think what perhaps we've been able to do that maybe is a little bit different is we've kind of created an infrastructure or a platform through which the organisation can more meaningfully, as a statutory body, engage with those voluntary sector community organisations. That it's often quite difficult for the statutory sector and the voluntary sector to work together. They're quite different beasts with different cultural understanding of how money should work and flow and what success looks like. So we've been able to create, if you like, a Spotify for the NHS. We don't own the wellbeing and mental health community artists that people want and need to access, but we create that platform through which they can download them at a given point in time without having to worry about some of the complexity or the politics of how you bring those relationships and interventions into play for their journey.
So just kind of testing the edges of the model and how it works. I guess my knowledge of Liverpool probably stops when I left university there and Merseyside, but it's a very diverse area. There are, for want of a better word, posh bits and less posh bits. Do you find that there's consistency in terms of the availability of community things to put people in perhaps some of the economically more challenging areas?
I think we still, as I say, have a strong and vibrant offer. In terms of consistency, I think sometimes we do have duplication. So we may have lots and lots of organisations, but perhaps they're doing similar things. And I think maybe actually in certain areas you have pockets where there isn't someone doing it, or there's someone doing something twice rather than them targeting the resources in a different way. And I guess that's what some of this platform enables us to do, is be more targeted around health inequalities in particular, in how we can channel particular community partners into particular areas.
Thank you. If you were kind of trying to set up a similar model in the current environment with the funding and commissioning being what it is now, do you think that would be possible?
It's really difficult. I think that's a fantastic question. I think when we started out, which is more than 9 years ago, we had a board that was willing to listen to the lived experience of its people, a creative appetite for risk, knowing that the conventional models are straining to keep up with demand, and a solid financial base upon which to plan. That's a much more challenging situation.
Where was the funding coming from primarily in that instance?
So primarily the initial intervention was probably in part some subsidisation from within our own resources, but probably creative redesign of things that we were already doing. So since Liverpool had been capital of culture, we had a range of cultural and creative programmes. We'd launched peer support models, we'd launched a recovery college model. So we were able to creatively redesign them. And I think this is where the possibilities still exist, because Mersey Care, since I joined, has grown by 3 times. And each time there's been another organisation coming to the fold, we've been able to look at teams, small teams and pots of funding that are socially focused. And within every NHS organisation, there are more of those teams than people actually realise. What we've been able to do is provide an infrastructure that makes them more effective, instead of them languishing perhaps in a clinical team where the main focus will always be registration, CQC registration and activity.
I guess we're sort of shifting away from the ICB model a bit at the moment, so I guess that's something that we have to look out for in whatever replaces it, is making sure that there's still those broad pots of funding.
Absolutely, and I think this is where there will be challenges, because I think there are challenges around funding. There are mixtures of how organisations are going to work, what commissioning will look like. However, a number of the interventions that we're supporting are actually ones that are growing at the moment and in recent times. So, for example, the individual placement support for supported employments for severe mental illness cohorts, that's something that actually is expanding through community mental health transformation funding even now. So I think, despite those challenges, there are opportunities as well if we're creative.
Do you have any data that kind of demonstrates the success of your model?
We through outcome measures that we've used, we've been able to demonstrate a statistically significant improvement in mental health and well-being. But more recently, working across the Cheshire and Merseyside system, we've been engaged in a data analytics piece. So because we're an NHS service rather than the voluntary and community sector organisation, we've been able to collect NHS numbers. Now, using that factor, we've been able to link data across a 5-year time slice. So the social prescribing platform that we use, we took a 5-year time slice out of that. There had been 16,000 people over those 5 years that had accessed the Life Room service during that time. We matched around about 7,500 NHS numbers, and we did a sophisticated matched cohort study in order to really understand the impact of Life Room's interventions. So we matched a cohort that hadn't used the Life Rooms with a cohort that hadn't. And when you drill deeply down into that in terms of the demographics, what we were able to see was a reduction in clinical care contacts in the use of CMHT, community mental health teams, GPs, liaisons, psychiatry, and early interventions in psychosis. Those are quite small in the first instance. There's a need to do further data analyses around this, but we're beginning to see that impact. And we see a greater impact still if the social prescription that we use is also employed alongside some of that health activation and behaviour change work that we do.
Thank you. I'm going to move on to Janine. Navigo is a not-for-profit social enterprise commissioned by the NHS and social care. Could you give us a bit more context on how the service came to be established and how you navigate any barriers that you face?
So we obviously in 2011 were part of the NHS spin-out, so we were under the right to request and became a social enterprise. In addition to that, we also have the Section 75 arrangements in North East Lincolnshire, so we provide both health and social care within an integrated model. And I suppose the uniqueness of that social enterprise model enables us to improve access for people. It gives increased autonomy. We can never go into a deficit position. That gives our staff clear autonomy and ownership. They own the out-of-area budgets, they own the social care budget, they own the health budget, and they have to drive that money gets well invested for the people that they're there to serve. So that autonomy drives a lot of our outcome and our performance. It also allows us to address the wider social determinants. So whilst we deliver and our core budgets come in from health and social care, we're able to deliver a much more rounded model. And I suppose it's been described by people that have been and visited as something that, you know, entwines services with people's lives, their families, their hopes and their future. We have courage, we have will, and we have inspiration in how we adopt our services. We see gaps. We use our own data and we use what our service users and carers tell us to see the gaps and with them design the solutions to those gaps. So that's why you'll see we have things like we own a garden centre. It does great social value in the local community. Local people spend there and that money gets reinvested into improving mental health for people in areas. We have our own, none of our auxiliary services are delivered by anyone other than people that have used our services. So people that have experienced services then use that value to then work and have meaningful roles and occupation. We have been able to set up supported living, home care charities to bridge gaps, find housing solutions for people, seeing those wider determinants really and being able to provide solutions. So by pooling the budgets and having access to money in a different way allows us to be much more innovative and creative in how we deliver services.
Brilliant. And yeah, kind of what's the kind of the benefits of your model in terms of making sure that the support remains integrated?
So we work, I suppose, resonates with what other people on panels have said today. We work very much on the ethos of people having somewhere to live, somewhere to work and somewhere to love, someone to love. And very much that integration. If you just see the health element of a severe and enduring mental illness, you can give an evidence-based treatment, but if you don't address the determinants and that are surrounding that, you're never going to succeed and you're never going to encourage recovery for those individuals. So very much the model works because we see people as people, we value people as people. We are an employee-owned mutual. We work on that relationship of everyone having that equal voice and say. And if you empower people and give people the power, they design their own solutions rather than us designing it for them.
I often think that with our drive to define mental health, kind of give it parity with physical health, we forget that the social determinants of mental health are often even greater than they are of physical health. Would that be your reflection?
Yeah, I think that's an absolute fair reflection. And I think, there are often, this is where stigma and building that compassion and understanding and empathy in local communities, the importance of neighbourhoods, and gaining their understanding of what a severe mental illness looks like, and what it is like to live with that, and what they can do as local communities to help support that around environments, around employment, working with local housing providers to take some of the risk away. So, a lot of people will be, banned from lots of providers. They won't provide them with solutions and they get stuck in a system. But actually, if we work in equal partnership, if you provide the housing, we'll provide the in-reach and the support around that, then, it's win-win for everybody.
Yeah, and I was, before I did this, I was a cabinet member for social care, and we set up kind of wet rehabilitation sites and things like that because we needed to break down that stigma, and I think that made a real difference. I can see that the chair is getting a bit twitchy about me going over my time, so thank you both for your answers and thank you for all the work that you do in your communities.
Thank you for that, Josh, and I'll hand swiftly over to Greg.
Thank you very much. So you've both been involved in trailing innovative models for delivering mental health services. Can you give me sort of just an idea of how challenging that's been to get this funding and support to be able to do that? And what are the enablers to scaling up the models once they've been piloted? Michael first, ma'am.
I think it has been challenging. I think you will hear lots probably around social entrepreneurship in this context, but actually for my journey it's been social intrapreneurship. How do you begin to change hearts and minds within a conventional psychiatric model? And that can be challenging. I think to be honest, the biggest opportunity probably is some of the challenge that we now have, because I think as an organisation we recognised we couldn't keep doing what we've always been doing indefinitely. So actually that gives you opportunity to think differently, be creative, to shift left into models that can be more effective whilst also actually being less costly. So I think the opportunity is perhaps that some of this stuff is not only the right thing to do, it's actually a more affordable thing to do.
Yeah, I think just to echo that, I think the pooling of budgets and resources allows you to then be really creative with your skill set. So what is the need for the local population? And then you can work with the local population then to design the solution. So that freedom of not having to put things into boxes of this is health money, this is social care money, this is voluntary sector money, enables you to actually deliver what is needed. It gets led by the people, and I suppose it's going back to your fundamental ethos. For us, we always say to our staff, is it good enough for your family? And if the answer to that is no, then we need to do the challenge and we need to change and we need to bridge that gap in a different way.
I mean, you've both been very positive. I suppose I wouldn't want you to go away from here without having the opportunity to describe what might be improved in that situation. So, is there, in terms of the funding and support model, is there more that could be done?
I think definitely there is more that can be done. I think there's a real risk in a current climate that actually we retreat back into what we know rather than thinking more creatively around the whole system approach and really taking seriously that shift left philosophy. I think that is going to be a challenge because people are making tough decisions right now, and in some of this is not mainstream commissioning. That means it could be at risk.
Janine?
What I would like to add in that, because they would never forgive me, organisation, if I didn't mention it. As a social enterprise, what I would say is that, we need to be on a level playing field, and as a social enterprise we have had restrictions put on us in terms of access to digital, access to capital monies, etc., which then creates a postcode lottery. So rather than being prescriptive around models, you know, one of the biggest barriers is if you've designed a solution that delivers the outcomes, then don't allow that to therefore become a barrier in the future around ensuring that that local population isn't a detriment because of the model that's been delivered in that area.
Thank you. And then we're sort of reflecting upon the sort of wider social needs of people with SMIs in particular. What action would you like to see from government, and indeed NHS England whilst it still exists, to enable services to better meet the needs of those people? Janine?
I think for me it would be around long-term sustainability and funding, and a recognition of the demand and the increased demand from a mental health perspective, irrespective of the model that's being provided. Not being prescriptive around your model, but focused on outcomes so that local place bases can design their own local solutions.
Sorry, who's currently restricting you and being prescriptive about that?
I think the way guidance comes out often is prescripted, so community mental health has to deliver the following things, NHS talking therapies has to deliver the following things in the following fidelity to a model. Sometimes it's around what are people's hopes, wishes and visions, and what's the best way to deliver it, and place-based neighbourhoods should be designing what that looks like for their own neighbourhood.
Thank you. Sorry, I interrupted you.
It's okay. I think, yeah, the big isn't always beautiful element of it. Seeing health and social care in isolation needs to stop. That integration of all of that would drive much better outcomes for people. If we don't address the wider social determinants, people aren't going to recover well and retain their recovery.
Thank you. Michael?
I think I'd echo many of those comments, particularly around sustainability, a system-wide approach, but I think I'd add to that, take a whole person health approach here. It's not just about physical health, it's not just about mental health, it's not just about social health, it's about the whole wraparound that will actually deliver the outcomes for individuals and communities.
And being, don't want to put you on the spot, but are there things that NHS England could be doing differently to achieve what you're trying to do?
I think it is actually what I suppose I'll reserve judgment till I see what's in the 10-year plan as much as anything, because will the funding follow the rhetoric about those shifts to prevention and community and indeed to digital?
Thank you both very much.
Oh, thank you for that, Craig. And can I thank you both, but before you go, I'm going to do the same thing as I've done with the other two panels. So this is really quite quickly. 2 points. If there are two things that you want us to get from what you have just told us in the last half an hour, that you want us to ensure that we capture it and it's in our report, what would those 2 points be? And can I start with you, Janine?
Yeah, I think for me it would be, you know, we work on the mantra of culture kills strategy. And, you know, if you get the culture right and we start working in a much wider way, addressing the wider social health determinants, that will drive positive mental health outcomes for people. And the long-term sustainability would be my other.
For that, and over to you, Michael.
I would say as the first one, definitely that flowing of the funding is shifting left. The second one would be to give real attention to how the voluntary sector and the NHS can relate. They often speak very, very different languages, and you've got to get that right if both sectors are to work in harmony and deliver the outcomes.
On that note, can I say thank you both so much for joining us today, and the questions have been absolutely brilliant. So can I ask you to step back to your seats, and could the final panel please join us at the front, and that will be Professor Steve Pilling and Professor Belinda Lennox. Have I got that right? Lennox, yeah.
You're not
allowed to sit together for too long.
You know what now?
Right, can I welcome you both to the committee today, and can we start, ladies first, can we start with Professor Lennox? Can you please introduce, Have I said that correctly?
Yeah, it's
Sorry,
fine.
you frightened me there. Can you just introduce yourself, your title, and why you're here today? Thank you.
Hi, good morning, everybody. My name is Belinda Lennox. I'm a professor of psychiatry in Oxford. I'm head of department of psychiatry, and I undertake clinical work in severe mental illness, particularly psychosis. I work clinically in early intervention in psychosis services.
Thank you. I'm Stephen Pilling. I'm a professor of clinical psychology, also head of department at University College London. And by background, I'm a health service researcher, and I also do some clinical work in one of the local trusts in North London.
Thank you both. And I'm asking the first question. So my question is, can you briefly talk through the aims and the remit of the Odessi trial? And within that, can you share any preliminary results with us, please?
Yeah, well, that's a very good question. I'm very happy to do that. But I have to kind of issue a bit of a health warning, unfortunately. We do have the preliminary results, but we don't have them fully for the health economics, and we have not had them signed off either by NIHR, the funders, or by the Programme Steering Committee. So I'm going to have to be a little bit cautious, I'm afraid.
We appreciate that.
I think within about 3 months we should have the results, and if it would be okay, I would forward them to the committee at that point if you find it helpful. So that rather damp introduction to it, I'm afraid. And maybe if I could just say a little bit about the trial. So the trial is a large multi-centre cluster randomised trial where we're comparing open dialogue. This is an intervention, in fact, developed in West Lapland some 30 or more years ago. But the essential ingredients of it are, it's a team-based model which provides immediate help at point of crisis and continues to provide care throughout the episode of care, with a single practitioner often having that, not just the case coordination, but a central role in delivering care. A couple of other things that mark out the open dialogue approach are an emphasis on network meetings. There's an intention to try and involve the family and beyond carers and friends in initial meetings. And the purpose of the central focus of the programme, independent, if you like, of the diagnosis, and I'll say a little bit about that in a minute, there's an attempt to develop a shared understanding of the problem and a wish to have the individuals themselves as central decision makers in the nature of the care that they provide, and as a consequence tolerating a degree of uncertainty at the beginning about how the programme may develop. It's also right to say, though, that it's very much about promoting the use of effective pharmacological and psychological interventions, of which we know there are many. It's not saying it has an answer to everything. It's clearly effective treatments, and it's often helping people to better engage with them. And the hope is that, as a consequence of that, people begin not just to, their mental health improves, but they develop a better sense of agency and autonomy, able to take more of a role in managing their own care. That's the intervention. I could, if you want, say a little bit about the training and development, or maybe move on to Professor Lennox at this point.
A little bit more about,
right.
Even though you can't give a lot of information, right, about the results, the preliminary results, what your views were.
Yeah, well, and just
or just a sentence.
Yeah, no. I can say a bit more than that. Just a question of why we did it. I should have said in the introduction that I've had a couple of spells as advisors to the Department of Health, and one was some years ago developing what was called the functional team model, where we had a crisis team, an assertive outreach team, a community team, first episode services we'll hear a little bit more about. But actually we got to a situation, whereas I put it in the development of a further programme, the Community Mental Health Framework, that we had sort of, if you like, a team for everything, but a place for no one. There was a state at one point where there were more referrals between services than there were in and out of mental health services. And so that was one of the incentives behind a wish to explore the possibility of what open dialogue could bring. What we were interested in measuring, and this comes to the outcomes, I'll try and get through that fairly quickly. We were interested whether, first of all, people got better they recovered, but crucially, they stayed better. So we had a measure which is called time to relapse after initial recovery. It was developed by colleagues in South London, and we felt that that was an appropriate, robust measure. We also measured a range of other things, and these include, and that's that primary outcome I don't think I can say much about. We also collected quite a lot of data on hospital and general service usage. What I can say is that in the Open Dialogue programme, there's better long-term engagement with the programme, and that had impacts, which you should learn about shortly, on the use of hospital beds. We also looked at people's self-defined recovery, and we looked at people's overall experience of care. And shortly we'll have answers, I'll be able to give you the answer to all that. Other things
Professor
I think...
Pilling,
sorry, yeah.
You've talked about better long-term engagement, you've talked about people got better, stayed better. My question is, do you feel that the Odessa trial was proven?
I think what I can say is that, having seen the interviews, I'm in a fairly positive mood. But there are some caveats to that which I can't go into.
Yeah.
One thing I can say that actually impressed me is that in the Open Dialogue programme we had much better staff retention. And it's a multidisciplinary training, and if I'd spent a lot of time in working in psychosis, as Professor Lennox has, and actually having people around, being able to talk to people, being able to work out your plan, and having that validated by the team is actually quite a powerful intervention. And we saw that in staff retention, in the, I think I can say this, in the general satisfaction with care.
Right, that's awesome. Well, what we'll do, we'll move straight on to Belinda Lennox. The question I've got for you, the establishment and the expansion of early intervention in psychosis services have been identified as a good example of good practice. Why do you believe this should be seen as such a successful intervention?
It's quite interesting we're sat here together because I suppose EIP has been, I think, something we can be really proud of in NHS mental health services for the last 25 years, and we have a really robust evidence base. But actually the introduction was in the absence of very good evidence, but it just sort of made sense to everybody. So it was a sort of a bringing together of patients, of charities, of clinicians, of scientists, all saying the same thing, that intervening early and giving holistic wraparound care to people just made sense and was better than the alternative. So they've been around since 2000, and I think we should be really proud. They're accessible to everybody across England. We have a national clinical audit that measures the quality standards of the delivery of that care. Over 70% of people access EIP services within 2 weeks of referral, and referral can come from anyone, whether that's self-referral or through a GP or whatever. We can demonstrate that they're cost effective. They save the NHS money. So we calculated that £4,000 per person per year is saved, mostly because of preventing admission to hospital. We can show that people are more likely to be employed, 116% more likely to be employed if you're under an EIP service, and 52% more likely to be housed in mainstream housing. So these have real-world, tangible benefits to people taking part. The other key aspect is the involvement of families and carers. And that, again, is the key, one of the key predictors of satisfaction with the service is the involvement of families in the treatment of the individual.
So my follow-on question is, do you believe there should be any other specialist referral pathways established for the work that you're doing?
I think we've got to follow the evidence base. I suppose my key message is really that research is vitally important. We have effective treatments that we need to make sure are implemented everywhere, but we also need innovation. We need new developments and new ideas, and we need to robustly evaluate them, and then if they're effective, be able to spread them out very widely, very rapidly. So of course there are things that need, there's desperate need for new treatments and new pathways. I'm thinking particularly for people who don't respond to treatment, who have enduring psychosis, schizophrenia, and complex needs that aren't well served at the moment. So having that ongoing recovery-focused treatment, I think it is absolutely essential. The assertive outreach approach, if you like, that has been somewhat lost since it was originally introduced.
So my other question to you, moving on, why do you personally feel it's been such a success?
I think several factors. I think there was, when it was established, it was a different time. It was in the NHS plan. It was very prescriptive as to what you had to do. Trusts then sort of interpreted the rules slightly differently, but the introduction of the access and waiting time standard in 2016, I think, was transformative because it was clinically meaningful. So it wasn't just time to access care, it actually said it was access to evidence-based treatments, and the outcome measures that were recorded were meaningful and evidence-based. So it was evidence-based psychological treatments, social treatments, physical health care as part of the provision. I think it made sense to everybody, really.
Right, so my last sort of question to you around this area is that we had someone from the Royal College of Psychiatrists come to see us, a Dr. Lade Smith, and what he said that he felt there was actually an erosion in early intervention psychosis. So the question I'm asking you, do you have any concerns that it could be eroded, and even with all the fantastic work that you've done, could those services be eroded in the future if we don't guard them? The sustainability won't be there?
Thank you. Of course, I'm concerned about that. The main issue is the lack of ring-fenced funding that has to go to EIP service. That is not in place. So it's human behaviour that people perform against the measures that are recorded. But what isn't recorded, and I think should be, are, for instance, the team makeup. So the key predictor of a good experience with an EIP service is having a care coordinator and having a low ratio of patients to care coordinator. But actually the range provided in EIP services at the moment is sort of 1 to 7 to 1 to 35. Yeah. So actually being more definitive about what a good service looks like would be very helpful.
So going back to both of you, starting with Professor Paling, I know you can't tell us as much as I'd like you to tell us, so I'm going to own it. I'm going to own it, but do you think there are any policy areas that could help support what you're doing, or that need to be looked at, or what have you, that needs to be added so that you can actually see, or with what you can't tell us about, I'm feeling very confused here, but that we can move forward with?
I think it would just echo quite a bit of what Professor Lennox has just said. I think we have, in the open dialogue model, a clear idea about the central coordination of care, and Professor Lennox mentioned case management, that link with an individual practitioner who's got the time to respond at points of crisis and at other times is essential, and keeping the caseload limits at a reasonable level is an essential part of that. The other element of, I think, is effective and continuing training. We probably trained about 1,500 people in support of the trial. It's a 4-week training, it's multidisciplinary, and it helps build the shape of the team. So I think a focus on continuing training and continuing professional development is essential. And then the other one that again just came up is about outcomes. We've got very good evidence that the robust measurement of routine outcomes, and that means, I think, at each contact with an individual drives change. You see that in the NHS Talking Therapist programme. where you contrast adult and child programs. The adult program had routine outcome measurement, the child program didn't. The improvement in outcomes in the adult program is startlingly better than in the child program. And I think getting that built in is an essential component of it. We produced I work with the National Collaborating Centre, we recently produced a set of recommended outcome measures for secondary care mental health services. Unfortunately, they weren't mandated. I would actually like to see them mandated and say that you've got to be doing that, you've got to report on them, and crucially, make those reports public so people can actually see what's happening in the services that you yourself may be in receipt of or your family members may be in receipt of. So I think driving good outcome measurement and good outcome reporting drives positive change. I think it should be part of what we do.
Thank you for that, Professor Palin. And from yourself, Professor Lennox?
So my 2 points are that the commitment to research funding as a core part of all NHS business and mental health, community mental health services should be established. So the mental health investment standard is very welcome, but I think a mental health research investment standard would be equivalently required. We have the National Institute of Health Research, but actually maybe a National Institute for Mental Health Research to ensure that dedicated funding for the evaluation of new service models and new treatments. And my second point is around mental health estate. So I know that point has been made by the Royal College in their submission as well, but we really have a crumbling infrastructure and estate, and that feeds into the discussion about stigma, actually. So if I'm coming to the building where I work, which is the hospital that's been in longest continuous use in the NHS since 1816, then I don't get the impression of a high-quality modern mental health service. So our plans to redevelop that alongside a new neuroscience centre, I think, some commitment to modernising the estate would be important.
Thank you for that. Jen, did you have a supplementary before I bring
Yes,
Joel?
and I'll be very brief. Thank you, Chair. The early intervention pathway on psychosis is particularly interesting. And I know that, and I may have got this wrong, but that you said that you kind of just sort of did it, but without the evidence to say that it might work, because it seemed fairly obvious that it would. Are there other areas? Because you did say there is a need to have the evidence base before you take this forward. And I'm thinking particularly maybe like a bipolar pathway, where maybe just doing it and then evidencing afterwards would be appropriate.
I know, it's just very difficult to do health services research. I mean, as an example, I put forward a proposal and was funded by the NIHR to evaluate an extended time for early intervention services, because they're 3 years in length, which doesn't make a lot of sense. Well, what about extending it to 5 years? The NIHR funded it, but the NHS said they couldn't provide the funding for that, for instance. There are lots of areas, absolutely, that there's the risks as well. So we've got to be rounded in our evaluation. The risk of having, silos, of having disorder-specific pathways that then exclude other people. The big issue for me as an early psychosis researcher is people with comorbidities, the large amount of drug misuse, the large amount of people with autism who get very little service otherwise. So everything is provided by us, but it's a lack of evidence as to what we should be doing.
It's just helpful how it interplays with some of the community-based services that we've seen as well, where there feels like there isn't that ability to necessarily data capture what they do, and how that interacts with more sort of NHS state-provided services. And if there was a way to do that, would that be transformative to how community healthcare is?
Well, it absolutely would. And just 2 bits of information relevant to that. So in the part of the world I work, we have just had social work withdrawn from our community teams to meet, is it Section 75 responsibilities? They have been integral, particularly in older people service, absolutely integral to the delivery of care, and that's now gone. And the other one, other people mentioned it earlier, is the impact of wider social factors on people's health. We were asked, Simon Wesley was doing a review of the Mental Health Act, and we were asked to look at what changes in mental health law might have impacted on the increased use of Section 135s or Section 23s. We plotted them along the bottom of the graph on the x-axis, things like Bournemouth, the introduction of doles, West Cheshire. And we also put two other points in the curve along the x-axis. And it was those two other points that led to the increase, the inflection in the curve, about a 10-15% shift in 135s and 136s and in 2s and 3s. It was nothing to do with mental health law changes. It was a global financial crisis, and it was the beginning of austerity. And those, you're right, those social determinants have powerful impacts on them, and we need to be able to be resourced to address the consequences of them.
Thank you.
Thanks for that, Jen. Can I go swiftly over to Joe for the last question?
Beyond what we've already discussed so far, are there any other areas of research that you believe could be most transformational, improving outcomes and experiences? Yeah, I do. To both of you. Yeah.
I suppose, yes, lots. So we haven't explored the use of digital technology. We haven't discussed that yet, but I think some of the research that some of my colleagues have done is really exciting and shows a lot of potential. So particularly with people with severe mental illness, I want to mention the work of Daniel Freeman, who's a colleague of mine who's developed a virtual reality intervention called Game Change for people with severe anxiety and agoraphobia who often can't leave their house and are severely disabled because of that, people with schizophrenia and psychosis, and has demonstrated a significant improvement with a virtual reality intervention. So completely outside of sort of normal level of care provision, but that's an exciting potential. We've done a lot of work on delivering psychological therapies using digital means, and again, it's you've got to evaluate that carefully actually, because it's not for everybody, and there's large risks of excluding people that can't use those technologies, but really promising results for childhood anxiety, for instance, showing as effective results and reduced clinician time. They're now NICE recommended, and a very widely used treatment for insomnia, Sleepio, that was developed by our academics, and that can demonstrate reduced use of GP time, increased productivity at work, and 75%, 76% improvement for everybody that uses that app, for instance. So really novel, different ways of delivering care.
I've been involved in two of those trials. They're excellent. But just to pick up on another point, which is, this is a bit of a sorry tale, but if you look at the treatment of depression, we have not improved pharmacological or psychological outcomes since respective the 1950s and the 1960s. We haven't got bigger effect sizes than the early imipramine trial or the early Rush trial. And that's a problem. And it's not because we don't deliver effective treatments, we do, but we haven't got the added benefit that you've seen, for example, in the treatment of anxiety disorders. So I think the research issue is a challenge to track back down the developmental pathway. The median age of onset in depression is 24. It's a disorder that emerges in late adolescence, early adult life, and I think a priority of researching both preventative and early interventions to try and reduce the long-term incidence and impact of depression. It's the biggest cause of suicide, for example, is another area where we ought to be putting our efforts. So early intervention, prevention in depression would be one I'd put up there.
Can I mention then that actually the innovation, so from the Office of Life Sciences and the NIHR have invested in the translational research collaboration for treatment-resistant depression with an infrastructure across the UK. It's actually hosted in Oxford, but for clinics for people with treatment-resistant depression, where you have access to innovative treatments coming down the line. We've done trials of repurposed drugs used in other conditions that we can show are hugely effective, because you're right, we really need advances. New therapeutics being developed by pharmaceutical companies, it's been a bit of a desert for many years, but actually it's an exciting time. There is renewed interest in neuroscience and in mental health, and conversations and new compounds, genuinely new approaches to treatment are coming down the line. So we really need to be ready for that.
And we need them earlier along the line, is the point. I think it's 50% relapse for one episode, I think you're in the 85%. So if you've had 3 episodes, it's a lifelong disorder, and new treatments will help. But it'd be nice not to see so many coming through in the first place.
Yeah, we need to understand the causes to start with.
Oh, thank you for that. Bless you. Can I just ask one last question? You talked about research, and you highlighted the fact that there wasn't enough research. Could you give us a reason why? Why is that body of research not there? Because this isn't something that is new.
Oh my goodness. Okay. Investment in mental health research is almost entirely funded by the government. So other areas of medical research have a lot of public contributions. So we always compare against cancer because we're impressed at their amazing ability to raise money. So we have about 1/5 of the funding going to mental health research. And actually, if you take it with the numbers of people affected, then 25 times more is spent per person with cancer than it is on a person with mental illness. So that's the number one point. Number 2 point are the academics. Actually, academic psychiatry is in crisis, and I would say academic psychology similarly in the UK. There are many medical schools around the country with no academic psychiatrists, so the hope for training the next generation is really being lost. So it's actually the numbers of people, and the reason for that is because most individuals have traditionally been paid for by the NHS. We've been reliant on the NHS to pay for the research funding, and that is a problem.
Sorry. Did you want to make a final point?
One thing to that. I agree absolutely with what Belinda said, and I think UCL Oxford are exceptions. We do rather well, but I think a broader issue is what deters people, whether they're young doctors, clinical psychologists, or others coming in. And I think sometimes the national critique about mental health services, where things go wrong, does not help us in attracting good, bright, young researchers into the field. So I think it's a responsibility for us, it's a responsibility for the government to fund it, but I think there's a wider public debate about what we say about mental health and how we respond to things. When things go wrong, it doesn't create the right environment, and it would be nice to see it change.
Thank you for that. Professor Pilling, Professor Lennox, fantastic responses. The meeting has now come to an end. Order.